A discussion by Dr. Louis Lasagna, Dr. Rene Menge, Dr. C. Harold Melke, Jr., and Dr. Max Samter.
The relief of pain with mild, non-narcotic analgesics seems to be one of the most common requirements of our society today. Certainly aspirin, generally accepted to be the most therapeutically effective non-narcotic analgesic for reducing pain, fever, and inflammation, is the most widely used of all the drugs consumed by humans. In the United States, consumption of aspirin alone or in combination with other drugs has reached tens of thousands of tons per year. For the average person, occasional doses of aspirin produce satisfactory pain relief with no ill effects. But there are other millions of our patients who cannot or should not take aspirin or related drugs, especially in large doses or over long periods, because of occasional, severe, unwanted effects. We will attempt to define these so-called problem patients, to explain why they have a problem, and to suggest what kind of therapy can be substituted for the relief of their pain. I am Dr. Louis Lasagna of the Department of Pharmacology and Toxicology of the University of Rochester School of Medicine and Dentistry. 3 distinguished clinical investigators will join me in discussing some of the problems associated with mild analgesic treatment. Dr. Rene Menge is professor of surgery at the University of Rochester School of Medicine and surgeon-in-chief at the Genesee Hospital in Rochester, New York.
One of the problems encountered in the chronic usage or overdosage of aspirin is gastric mucosal injury causing upper gastrointestinal bleeding. Particularly in patients with ulcer disease, this may cause severe anemia or massive hematemesis.
Dr. C. Harold Melke, Jr. is head of the Blood Research Laboratory at the Institute of Medical Sciences of the Pacific Medical Center in San Francisco.
In recent studies, we have been able to demonstrate that one of the characteristics of aspirin is alteration of bleeding time and platelet function. This effect occurs with everyone and can be caused by a single tablet. It is little consequence to most people, but it can be a serious complication in the treatment of patients with hemophilia or those undergoing surgery or anticoagulant therapy.
Dr. Max Samter is professor of medicine at the Abraham Lincoln School of Medicine of the University of Illinois in Chicago.
My specialty is allergy and clinical immunology. We have carried out extensive studies on patients who have a critical sensitivity to some minor analgesics, including aspirin. Many of these patients can be recognized in advance by the presence of nasal polyps and bronchial asthma. Their reactions to aspirin might be mild, moderate, or severe, and may range from angioedema and urticaria to a condition which closely resembles anaphylactic shock.
In addition to the problems mentioned by my colleagues, children face the additional danger of aspirin overdosage, either accidental or due to misguided parental overconcern.
The danger of misguided overdosage is a very real one for adults, too. Through informal but nevertheless extensive interviews with patients, we found that many individuals who take aspirin occasionally for aches and pains will also take this drug for the prevention of a possible headache, for instance, after the overindulgence of alcohol. We've also found that many people fall into the habit of taking aspirin regularly at bedtime in the mistaken belief that it has sedative properties. An even more serious problem is the fact that aspirin is incorporated into so many proprietary preparations for aches and colds and so on that many people take aspirin without knowing that they're doing so.
Too true. So then, for the most part, we will confine our discussions of drugs to the 2 most commonly used non-prescription agents, aspirin and acetaminophen. Both are mild, non-narcotic, non-steroid analgesics. Both are also antipyretic And aspirin has the added advantage of being anti-inflammatory. But time limitation does not permit any lengthy consideration of these two characteristics.
Today, the bulk of laboratory and clinical evidence suggests a strong association between upper gastrointestinal bleeding and aspirin usage. The soundest proof for this association lies in the ability to detect upper gastrointestinal bleeding by the accurate chromium-51 technique in normal subjects following the ingestion of aspirin. For example, Leonards and his associates measured blood loss by the chromium-51 method in the stools of 57 healthy subjects taking 2.6 or 3.9 grams of aspirin daily for 8-day periods. During drug-free control periods, the average daily blood loss was 0.5 milliliters. But during the aspirin ingestion periods, blood loss averaged 3 milliliters above control values. I should add at this point that one of the most puzzling aspects of the aspirin bleeding problem is that significant bleeding leading to anemia or overt hemorrhage occurs only in certain susceptible individuals or under certain particular circumstances, such as the prior overindulgence of alcohol. In recent and classical clinical studies, Muir and Kosser of Great Britain showed that in 1 out of every 7 or 8 patients admitted to a hospital for overt upper gastrointestinal bleeding, aspirin appeared to be the responsible agent. Occult bleeding, on the other hand, may go unrecognized for months and years, and a patient may simply attribute his shortness of breath, his inability to climb stairs, to tired blood, without recognizing that the anemia is due to the chronic use of aspirin. This particular problem is more likely to occur in patients who are taking aspirin chronically for such things as rheumatoid arthritis or osteoarthritis. Aspirin-induced gastric erosions have a characteristic appearance on gastroscopic examination. This 24-year-old woman had taken 9 grams of aspirin over a 12-hour period for the relief of a very bad hangover. I want to re-emphasize once again that one of the factors which definitely appears to potentiate the action of aspirin on the gastric mucosa is alcohol. And one of the worst things that a physician can do is to prescribe over the telephone a shot of whiskey, 2 aspirins, and go to bed for someone who calls in with the flu. The gross appearance of gastric mucosal lesions produced by aspirin range from focal hemorrhage to circular areas of hemorrhagic necrosis and punched-out erosions. Microscopically, the lesions take the form of diffuse mucosal hemorrhage or focal hemorrhagic necrosis involving the full thickness of the mucosa but not extending deeper than the muscularis mucosae. Because of the belief that part of the injurious action of aspirin on the gastric mucosa is due to a local irritating effect, attempts have been made to prevent this complication by various pharmaceutical manipulations, such as enteric coating or buffering. And there is some evidence to indicate that aspirin in highly effervescent, highly buffered solutions is less injurious to the gastric mucosal membrane. Yet I wish to re-emphasize the fact that aspirin is not entirely free from risk in any form. It is probable that aspirin does have a direct topical action on the gastric epithelium. However, available evidence suggests that an important contributory role is played by the presence of the intact molecule of aspirin in the circulation. Our studies have indicated that aspirin affects both components of the gastric mucosal barrier, which protects the gastric epithelium from the action of its own secretions. The first component of the mucosal barrier is gastric mucus. This is a thick, viscous secretion that adheres tenaciously to the underlying mucosa and forms a continuous layer separating the surface epithelial cells from the lumen of the stomach. This mucus is constantly undergoing degradation by digestive and bacterial enzymes. At the same time, it is continuously being renewed. The second component of the mucosal barrier lies in the ability of the surface epithelial cells lining the stomach to renew themselves continuously. We suspect then that the following chain of events leads to gastric erosions with hemorrhage and/or anemia in human subjects who have consumed aspirin. When aspirin reaches the cells of the gastric epithelium, it causes a specific cellular damage resulting in a reduced output of mucus and a loss of intercellular adhesiveness. In all likelihood, aspirin reaches these cells both via direct absorption through the gastric mucosal membrane and through the circulation after absorption from the small bowel. The net effect is an increase in the rate of shedding of the surface epithelial cells, shedding which then becomes more rapid than the rate of renewal. The net result is a breach in the integrity of the gastric mucosal barrier. In summary, the injurious action of aspirin on the gastric mucosal membrane may become manifest in three ways. One, occult bleeding with iron deficiency anemia. Two, overt upper gastrointestinal bleeding. And three, a chronic gastric ulceration. This latter complication of aspirin is more likely to occur in women who are habitual users of aspirin.
It is clear from these comments that an inquiry regarding aspirin ingestion should be routine whenever working up a patient with occult bleeding, especially when the bleeding cannot be related to peptic ulcer, gastric cancer, esophageal varices, or peptic esophagitis. Aspirin ingestion should also be suspected when gastrointestinal bleeding follows soon after a bout of alcoholic drinking.
In prescribing for pain relief, it is well to remember that there is no form of aspirin which is entirely free from the risk of gastrointestinal bleeding. This is particularly true in patients with peptic ulcer disease and gastric hyperacidity and in individuals with blood dyscrasia. Under these conditions, a safe analgesic free from this complication, such as acetaminophen, should be substituted for aspirin.
A number of studies comparing the action of aspirin and acetaminophen in relieving pain and reducing fever have demonstrated equivalent effectiveness following a single dose. In our own studies, we have compared the analgesic effects of aspirin, acetaminophen, and a placebo in women during the period just after giving birth. 600 milligrams of acetaminophen proved as effective as an equal dose of aspirin in relieving pain. Our conclusion has been that acetaminophen in commonly recommended dosages is an effective analgesic which can be satisfactorily substituted for aspirin. Although the two drugs have shown generally comparable performances in alleviating pain and reducing fever, we must keep in mind that aspirin is superior to acetaminophen as an anti-inflammatory analgesic for the management of patients with rheumatoid arthritis.
I must agree with Dr. Lasagna about the superior anti-inflammatory effects of aspirin in the treatment of patients with rheumatoid arthritis. However, the doses required are sometimes very large. and may be capable of causing gastric bleeding and or chronic gastric ulceration. This must be weighed very carefully in planning the long-term management of these patients.
Dr. Menge has confined his comments on gastrointestinal bleeding to the effect aspirin has in penetrating or breaking down the gastric mucosal barrier. There is another side effect of aspirin, the alteration of platelet function with resultant prolongation of bleeding time, which may also play a secondary role here, but which is certainly a major consideration in the treatment of patients with hemophilia and those who are receiving anticoagulant therapy.
It has long been recognized that salicylates have a deleterious effect on hemostasis. A rather voluminous literature indicates that aspirin may cause increased capillary fragility and bone marrow depression. However, the effect of aspirin on bleeding time is probably the most important consideration, especially for patients who may have a more or less chronic need for mild analgesia. In our laboratories, we have been particularly interested in comparing the time, pattern, and intensity of bleeding following ingestion of aspirin and acetaminophen, and in attempting to define the effects of these drugs on hemostasis. We have used a new semi-automatic method for recording these bleeding characteristics. The method we use is the template bleeding time. This is a controlled method which may be easily reproduced and verified by other investigators. The drops of blood are blotted at 30-second intervals. The filter paper acts as a record of the bleeding characteristics. The end point is reached when blood no longer stains the filter paper. In a study of 124 normal volunteer subjects, we found the mean bleeding time to be 5 minutes. The range was from 2.5 to 9.5 minutes. In this normal subject, the bleeding time was 5.5 minutes. She was then given 2 tablets of aspirin, and 2 hours later, her bleeding time had increased to 11 minutes. In another study of 60 normal subjects, we found that 2 hours after administration of 2 tablets of aspirin, the mean bleeding time was raised to 11.5 minutes, more than twice the time during control periods. Acetaminophen, administered in equivalent therapeutic dosage to the same subjects, did not produce a significant change in bleeding time from the control levels. We further found that after a single dose of aspirin to normal subjects, peak prolongation of the bleeding time occurs in approximately 6 hours, and this prolonged time does not return to control levels until the 5th to 7th day. Incidentally, we believe that this effect is not dosage related. 1 tablet of aspirin seems to have the same effect as 10. We also did a chronic study over a 3-month period to rule out resistance to the medication. 2 normal subjects received 1 aspirin tablet daily for 11 weeks. The bleeding time remained strikingly prolonged throughout this study period. We believe, as a result of a number of in vivo and in vitro experiments, that the prolongation of the bleeding time produced by aspirin is primarily due to alteration of platelet function. According to current concepts, the primary defense against small vessel bleeding is formation of a hemostatic plug at the site of injury. Whenever a blood vessel is severed, there are several mechanisms which act to arrest the bleeding. First, there is a reflex vasoconstriction of the vessel which impedes the flow of blood. Within seconds, platelets adhere to the exposed collagen of the injured vessel wall. Adenosine diphosphate, or ADP, is released in small amounts, and platelets aggregate by adhering to each other to form a loose, reversible hemostatic plug. During aggregation, platelets swell, degranulate, and release several vasoactive substances, of which ADP is the final common pathway for the induction of platelet aggregation. Within a matter of minutes, this plug enlarges, and in the presence of trace thrombin, it is transformed into an impermeable hemostatic plug. At this point, the flow of blood ceases, and hence the end point of the template bleeding time. With aggregation and the formation of viscous metamorphosis, platelet factor 3 is made available and the intrinsic clotting mechanism is activated. Thrombin is formed and plasma fibrin is laid down, forming the stable hemostatic plug. The clot retracts through the action of platelet thrombosenin and normal hemostasis is accomplished. It has been demonstrated both in vivo and in vitro that the ingestion of aspirin blocks the release of ADP from the platelets. Secondary aggregation is thus inhibited, preventing rapid formation of an effective hemostatic plug. This phenomenon is common to many non-steroidal anti-inflammatory drugs. In contrast to this, a well-controlled study has shown that acetaminophen, which lacks anti-inflammatory activity, has little effect on human platelet function. Knowing that aspirin prolongs bleeding time in normal subjects, we centered our investigations around disorders of bleeding, especially hemophilia. The hemophiliac is constantly plagued by painful hemorrhages, most commonly into the joint spaces. Aspirin has been used routinely to relieve this pain. But, although the pain was relieved, many patients noted that the hemorrhaging didn't improve and often worsened, increasing morbidity. 11 patients with severe hemophilia A and 8 patients with severe hemophilia B were challenged with 900 milligrams of aspirin, the equivalent of 3 tablets. Controlled bleeding times in these patients did not differ significantly from those of normal subjects. 2 hours after aspirin administration, however, 8 patients had marked prolongation of bleeding time, and 7 of these required transfusions to stop the bleeding. In another study involving 28 severe hemophiliacs, the prolongation of the bleeding time after aspirin ingestion was again marked, whereas the response to acetaminophen and a lactose placebo were insignificant. We have concluded from these and other studies that acetaminophen, in comparably effective therapeutic doses, does not have a significant aspirin-like effect on platelet function. Therefore, it seems preferable to aspirin as a mild analgesic for hemophiliacs and for other patients in whom prolonged bleeding may be a serious problem. There are roughly 100,000 hemophiliacs in the United States. It's difficult to guess the number of patients on anticoagulant therapy or who have minor bleeding disorders.
Dr. Melke has mentioned that the prolonged bleeding time produced by aspirin, even in normal subjects, may last for as long as 5 days. Apparently, then, ingestion of aspirin might result in bleeding problems, especially in the small surface vessels, both during and after surgical and dental procedures.
I think this might be an interesting avenue of exploration. It is now well accepted that aspirin may be responsible for bleeding problems when it's prescribed for pain after such procedures as tonsillectomy or dental surgery.
So far, we have seen that large or chronic doses of aspirin or other analgesics with anti-inflammatory action can produce some degree of gastric bleeding in practically all patients, and that even small doses of these drugs will certainly prolong bleeding time in everyone. Now we shall consider another group of patients, those who have an intolerance or dangerous sensitivity to a group of compounds, of which aspirin is one.
We are following more than 4,000 patients who cannot take aspirin. We think that this aspirin disease is not common, but it is not rare. The incidence increases with age. Up to 6% of middle-aged asthmatics might have an intolerance to aspirin. We believe that the clinical triad of nasal polyposis, bronchial asthma, and life-threatening reactions to acetylsalicylic acid is a disease entity and not just a random cluster of allergic symptoms. The natural history of the syndrome, that is, the date of the first attack, the severity of the reaction, and the progressiveness varies from patient to patient. Furthermore, all patients do not necessarily present every potential component of the syndrome. The precursors of the syndrome usually appear during the second or third decades of life as intermittent vasomotor rhinitis, distinguished by profuse watery secretions. This is eventually followed by chronic nasal blockade. The swelling of the nasal mucous membrane tends to respond less and less to vasoconstrictors, and nasal and paranasal polyps develop. Then, as a rule in middle age, bronchial asthma appears in these aspirin-sensitive patients.
Let me just listen to your chest. And take some deep breaths, please.
The initial reaction to aspirin in these patients is usually unexpected and quite often not attributed to the taking of aspirin. Furthermore, no correlation seems to exist between the frequency with which patients have taken aspirin in the past and the severity of their reactions once they begin.
Twice I remember taking medication with aspirin in it.
What was the last time?
3 years ago, my husband's medication.
What happened?
I took it thinking it was my own headache medicine. I started getting an asthma attack. I took one of my own asthma medicine. But within an hour and a half, I was in bed, laying in bed. The whole bed was shaking. And it took me 2 hours of this before I could realize what I had done.
Mm-hmm.
And by this time, I was just drained of all energy.
Once intolerance to aspirin develops, it does not spontaneously disappear. If intolerance is severe, reactions are quite typical. They begin with a profuse, watery rhinorrhea and are occasionally associated with a vivid scarlet flush of head, neck, upper chest, and extremities, the nature of which is uncertain. Nausea, vomiting, intestinal cramps, and diarrhea might be part of the syndrome. Bronchial constriction, wheezing, and cyanosis may occur within minutes after the onset of the reaction. With proper treatment, most patients recover from the acute reaction within a few hours, but a general feeling of malaise accompanied by excessive bronchial secretion may persist for several days. While aspirin is outstanding in its ability to precipitate severe reactions in these patients, other drugs and chemicals added to food might have just about the same effect. Since we are talking about pain relievers, it should perhaps be mentioned that morphine, morphine derivatives, and codeine can produce rather striking and severe reactions in some of these patients. We do not believe that the symptoms which precede the development of intolerance to aspirin are the result of an immunological sequence. We have suspected that the respiratory mucous membrane has been damaged and that aspirin gains access to a usually protected system of peripheral receptors, reflexes, and bronchial affected tissues. In other words, aspirin penetrates into forbidden areas and causes vasodilatation, secretion of mucus, and bronchoconstriction by direct action. The nature of this action, which is not understood, is under intensive investigation at the present time. For the time being, every patient who has nasal polyps and bronchial asthma must be suspected of being aspirin sensitive. He must be warned to avoid aspirin or any combination of drugs containing aspirin. Phenacetin and acetaminophen are safe, although we do not know the reasons why. If we knew, we would gain considerable insight into the nature of peripheral pain relief. It is amazing that it took almost 75 years and tons of aspirin to persuade us that an evaluation of its credits and debits is long overdue and that it might be worthwhile to look for a substitute which provides the blessings of aspirin but will keep us safe from its occasional transgressions.
We have shown that there is an appreciably large number of patients for whom the relief of pain and fever should no longer be considered a light problem. Treatment other than the casual take 2 aspirins 4 times a day must be considered for them. When inflammation is also involved, as in rheumatoid arthritis, the unwanted effects of aspirin must be weighed against the unquestionably effective relief provided by this drug. But when inflammation is not involved, the substitution of a non-anti-inflammatory drug, such as acetaminophen, is often the wisest course.